Yeah, with and without Valsalva. So the first one on the top of the chart. Now, my recommendation is for your, what did I call it? Your study guide thing that you do. Portfolio. Thank you. So for your portfolio, what I recommend doing is going through and drawing yourself a full diastolic chart diagram. Okay. So that way you're kind of sinking in. Okay, I need to get mitral inflow, and then what do I see in each of those stages? Do it with Valsalva. You need your tissue Doppler, you need your pulmonary veins, and you need your propagation velocity. Some charts don't have propagation velocity on them, some don't even have pulmonary vein inflow, stuff like that, but the more complete you can make your chart, the less you're going to be thrown by seeing a different chart, okay, that might be more updated. So there's different texts, have different numbers and stuff with that. So in addition, we're going to look at deceleration time that we take on the mitral inflow. You could have IVRT. You could have, what else do we have in here? So we've got deceleration time, IVRT, the pulmonary vein SD ratio. Now these are kind of extra things you don't really need to know because you can tell by the waveforms alone probably what it is. There's these other little pieces of information. If you want to memorize them, great, but you don't necessarily have to. So if you can get a complete chart, usually you can do it just visually looking at it and be like, oh yeah, it's this. So you don't have to know every single number per se, but if you're a numbers person, that certainly helps. So when it comes to numbers, I'm going to give you the ASE numbers. They're the ones that set the standard because each textbook might be slightly different. They'll be close, but not necessarily exactly the same. So we can kind of draw that out as we do these today. We'll write the numbers up with it. You're going to be looking at the A velocity. So remember that A reversal on the pulmonary veins. I said it usually gets a higher velocity and wider as we get worse. So there will be numbers associated with that. The propagation velocity is the mitral valve tissue Doppler velocity as well, particularly the E wave. And those are kind of the main things. So we'll talk about that and we'll kind of write them in as we go. Again, you're always welcome to come and look. I only have one copy of this, but this is the ASE book with like 200 chapters. It's great. But they're like 3-page chapters. They're awesome. But it's got some good references and stuff. So if you're ever curious about numbers, that's the book that we're going to probably base it off of. Feigenbaum is very close to that. In fact, in most cases, it's right on the money. Okay, so let's start off with normal. So what did normal look like? What does my E wave look like on mitral inflow compared to A? Okay, so it's larger. So I should have a ratio greater than 1 for the EA ratio. What else about it? So my deceleration time, so it goes up and then it comes down fairly quickly. We've got the diastasis in between, then we get the A kick. So as we get more abnormal, and it could be due to valve pathology, that deceleration time could change. If it's due to stenosis, it's going to look different because of the stenosis, okay, which is different from diastolic function. So kind of know what a normal looks like at this point, so then we can start separating it. What about Valsalva? What does Valsalva do on a normal situation? So we're changing the pressures by having the patient bear down. Okay, they hold their breath and bear down real hard. What does that do to a normal waveform? It depresses the whole thing, but my E and A ratio stays the same. Okay, that's kind of our key on that, is distinguishing what else is going on. Okay, we need to get a reversal. If it was looking normal, we cause that to change, and we'll talk about that when we get into pseudo-normalization. It's going to switch the two. Okay?
Hey Scott, I got a quick question about that. If
Yep.
you ask the patient to do a Valsalva and their E and A ratios don't diminish or come down a little bit, would you then maybe wonder if the patient isn't doing a proper Valsalva?
Yeah, it could be. It could be that the patient's just not pushing hard enough, and often the problem with doing Valsalva is it is patient dependent. I actually had a doctor that I saw in Blackfoot, Idaho once had a genius idea, and he got this idea from a cardiologist. This was a radiologist. He got the idea from a cardiologist, but what he did is he took a piece of oxygen tubing and he hooked it up to the pressure gauge, the blood pressure gauge on the wall, and he would have the patient blow into it to a certain level of millimeters of mercury. I don't remember what that was, but that way it was always consistent. So there are ways to get that, you know, accurately, but the thing is with tissue Doppler and stuff like that, we don't really need to do that. We can get enough information without that. So the Valsalva is great. It's kind of supplemental. You guys will be doing a lot for vascular exams, for venous exams, just to try to get that backflow through the through the valves.
Would you be able to do the same things like an incentive spirometer?
Yeah, possibly. As long as they're giving a certain amount of pressure out, that's what we're doing. So you could do that. Is it worth that extra time? Maybe,
Well,
maybe
like
not.
In hospitals, like almost every patient has one, like on the side of their bed.
That's true. So it's a good way to gauge the consistency of it, which is nice. Okay. So here or there, if you have those tools and techniques, then that's a great way to do it. You can impress your lab, but like, hey, I know a good way to make sure they're getting it. Other than that, we do have other sources to be able to determine if these are the level of impairment. Okay, and then pulmonary veins. What do we see normally in a pulmonary vein? So what components of waves do we have on pulmonary veins? We have systolic and diastolic. So, but the systolic has how many components? Possibly? Possibly two. So we have a S1 and S2. If it's a young, healthy individual, don't be thrown if they don't have it. Most people you scan you're not going to see it. And then we have the D waves. So the S waves all have to do with systole. The D wave has to do with diastole. And then what's the last one we have?
A-dur.
So the A-dur is the duration of that, but the A wave itself, which is reversed. So in a pulmonary vein, it's reversal of flow. And what wave do we compare that to again? So we compare the A duration on the pulmonary vein, and we also compare it to mitral inflow. Okay? So think of echo and all these measurements that we do. There's a lot of measurements, but we're doing a lot of repeat measurements. We're looking at the same thing from different perspectives, different waveforms that are comparing to similar waveforms on other types of modalities. Okay? All right, so let's start with grade 1. So this is the first abnormal stage, so when we're no longer normal. Oh, then we have propagation velocity, so know what is propagation velocity done with? What mode is it? It is color M mode. So not colorized as in the grayscale is colorized, but you're actually using color Doppler. So you put your color Doppler in. What view do we do it from? Apical 4-chamber view. We run it from the apex right through the middle of the valve inflow. Okay, and then we're looking at that aliasing velocity and the slope of that. That's all it is. Okay, so it's not very difficult to do. All right, so grade 1. Sorry, my ink is not very good. So this is diastolic dysfunction, grade 1, which was also called impaired relaxation. So functionally speaking, from a physiologic standpoint, what is happening when we're talking about impaired relaxation? When we talk about diastole, what's the walls actually doing?
Relaxing.
They're relaxing, and they should be fairly elastic. They should be stretchy and nice and pliable, and they are compliant, so they give fairly quickly. Okay. When we get into impaired relaxation is our first stage, so that just means that it's impaired. It's kind of slowed down from the relaxation process. So diastolic dysfunction is a relaxation problem. It's not able to relax very quickly like we are. It's kind of like when you exercise really hard when you're 25 and your recovery phase versus the recovery phase is when you're 45 or beyond. Okay? It just takes longer to do that. So just think of the heart the same way. It's just over time it's pumping a lot, right? I can't remember the beats per minute or beats number of beats per lifetime for a patient on average, but we're in the millions, probably billions. It works a lot. Your heart never stops until it does. All right. So impaired relaxation. What's the first thing we look at then? Mitral inflow. So what are our first signs on mitral inflow?
Increased A-level.
So we could take that 50-50 view, 50 feet away at 50 miles an hour. Just look at what your waveform looks like without having to calculate the numbers and stuff like that. Again, there are numbers associated with it. So what was that again?
Increased A wave.
So the increased A wave, and what's my E wave look like?
Smaller than A wave.
Okay, so this is E, A. And just to emphasize it, because again, when we get into these abnormal patterns, our inkling is to want to do what first? When we see just two waveforms, we usually take the biggest as the E wave, right? Because we want it to be normal. Okay, so what EKG wave does this correlate with? Or which ones can you locate to see where we're at? Okay, so R wave is systole. So E wave starts in systole? Starts in diastole, right? So what should it follow?
The mid-T.
Okay, so the end of the T wave. So we've got our QRS. Okay, so it should be roughly at the end of the T wave, and then we go into diastole. And the other good locator always is the A wave. So the A is associated with? Good. Okay, so timing-wise, always look at those things. So don't just make the assumption, even when you're scanning each other, don't just assume that everybody's normal, because you will be thrown by it because you'll think, oh yeah, it's good, it's normal. And you just go and measure the highest wave as the E wave, which is incorrect. Okay? So make sure that you're getting those correct, and it's just a quick correlation with your EKG. But this is the number one thing. So if I see this right away, I pretty much have diagnosed impaired relaxation. If it's kind of skating the line, it's kind of borderline, that's when the Valsalvas can help. And then the other information from the tissue Doppler and stuff can help. But if I've got a pretty distinct lower E wave than the A wave on a normal respiration, you pretty much diagnosed it. That's easy. So impaired relaxation is probably the easiest one to do. Then, what would Valsalva do to this? It just presses both of them down the same ratio. So it doesn't change anything as far as their relationship, it just pushes them all down. Because of increased pressure. So I'm not going to drop Valsalva because Valsalva doesn't really do much at this phase. What's our next one on the line usually? So tissue Doppler. Okay, so what does our tissue Doppler now look like? So as I talk through this too, tell me how you want to set up your Doppler. What kind of baselines and scales and stuff do you think you want to have on this? So we'll say it's just a normal valve as far as the function of the valve goes. So it's not stenotic or anything like that. Baseline up or down on this? So bring it down. Remember, never right to the bottom or the top, but this is going to come down most of the way because all I'm interested in is this side of the baseline. If we get into regurgitations, we're going to do separate Dopplers for regurgitations because those velocities for a mitral valve are up around 500 to 600 centimeters per second, so they're significantly faster. So if I'm measuring stuff, I want to measure it at its optimal size. So baseline down, what would my scale be roughly on this? So you're going to be, so most of these flows are going to be around 80 to 100 centimeters per second. So your scale is going to want to be set probably 100 to 120-ish. Okay, just FYI. So again, if you're struggling for these, you want to be able to set your baseline and your Doppler parameters up before you go into it. Because again, so you guys got to scan some renal parenchymal arteries last week, right? How was that? Is it hard? Very hard. So the tinier the vessels, the more difficult it is. So if your Doppler is set in the parameters that you need before you have to do the Doppler, you're much quicker to do some quick adjustments and stuff. You don't have to do that. So otherwise, you're going to have to make all the scale changes, baseline changes and stuff, and by that time, you've lost the artery and you have to reobtain it. Okay, so I advise that you kind of know where you're going to go, and when you start to get quicker, you're going to set it up ahead of time before you even start the Doppler. Close, and then you still probably have to tweak a little bit. Tissue Doppler, what about its baseline, and what do we see? What do we expect to see? Okay, so these on a transthoracic echo, they're always going to be below baseline as our waveform, so we're going to move the baseline up. Okay, so I'm just going to put this one baseline down, this one's baseline up, near the top. What about velocity? So this is up around 100 to 120 centimeters per second. What would I expect on velocities for tissue Doppler? Okay, so it's going to be much lower. So our velocity is going to be around 10. So I'd say on a normal individual we could be up to 20 centimeters per second. So a lot slower than this. So my scale should be probably down around 40 centimeters per second, just as a gauge. So normal should look like this, with a taller E wave or a higher velocity E wave than we do the A wave. Remember, we also get our S wave that comes in after that and stuff. That's the systolic. So, but we're interested in the E prime and the A prime. We'll ignore the S prime for diastolic because it's not part of diastolic. Okay, so that's what normal looks like. What does abnormal look like? Yep, so this is where it reverses. So this is the a true tell. Okay, so the velocity of the E prime is smaller than the A prime. Okay, so that will be true starting from impaired relaxation. So if I've got a tissue Doppler that's inverted, now I take two tissue Dopplers usually. Which ones are what locations do I take them at? Septal and lateral from 4-chamber view. Okay? Good, so if I've got that, that's a pretty easy tell. Again, if I saw this, it's just going to confirm what I already knew, but it's helpful to have. Okay? So that's tissue Doppler. Any questions on that?
So do you just want us to know when something is abnormal from the normal?
For this, I need you to know each of the grades because we're going through all 4 grades.
Every single one of the squares we need to know.
Yes.
Okay.
So don't think of it as an individual square, an individual parameter. Think of it as a column of parameters that are telling me the same story.
Okay.
So I've got my mitral inflow on normal. I've got my mitral inflow has E taller than A. Valsalva just depresses it, but it's the same. Tissue Doppler, E is taller than A. My SD waves are similar in height on the pulmonary vein inflow. My propagation velocity's got a fairly steep angle on it. So those are the types of things visually that you're going to be like, oh yeah, that's
For grade
normal.
1.
That's for normal.
For normal. Okay.
Yeah, this is grade 1. So grade 1, which is impaired relaxation, now my mitral inflow E wave is switched from the A. So visually you should be able to pick it up right away. I'm not usually going to give you just like one piece of information on a thing. It's like, what is the diagnosis? I'm going to give you the whole column.
Okay.
Okay? So know visually what the column looks like, and then if you need to break down the numbers to say, okay, this looks like this, but let's look at the numbers and distinguish what it really is. Okay, that's kind of what we'll go after. So for this inflow tissue Doppler, and then what does our pulmonary vein look like?
S and D wave.
Okay, so S and D are what?
Similar in velocity.
Or impaired.
Or not.
No, S
Your
is
S
bigger.
is bigger.
So S is bigger. So I'm going to draw normal first. So we've got kind of the S and D. They should be similar in height. A reversal, that's kind of a tall A reversal, but those are the components we see in normal. Okay. So D wave, we said smaller in this, right? And well, let's draw it significantly smaller. Okay, so my D wave. We'll just draw that as AR for, what does that stand for? The A reversal, yeah. So this is depressed a little bit, and what about our A wave? Okay, so let me see. So the impaired relaxation is still considered normal. So the AR velocity is going to be, it has to be less than 35 centimeters per second. Okay? And that's for normal and for impaired relaxation. So the A wave's not really changing yet. It will change in our next phase. Okay, so that's 35 per per second. So that is less than, my son's just going through this on his, on the alligator thing. It's funny, I'd never heard that when I was a kid. I just had to straight up memorize it. Welcome to the new age. All right. Okay, so any questions on this? So that's, this is pulmonary vein, so what's next?
Baseline and scale.
Okay, so yeah, so baseline and scale, where do we want it to be and roughly what scale?
Baseline, middle.
So not in middle, because which waves are biggest? So whatever I'm interested in should take up about 50 to 75% of the height of my screen, okay? So if the bottom of my screen should be like here, this one needs to be up here. So this is about 2/3 on the top, about 1/3 on the bottom-ish, okay? And again, I'm not necessarily testing on that. I just want you to know kind of which directions you should be pushing your stuff. Rarely do we ever have the baseline exactly in the middle, okay? Good. No other questions about that? So propagation velocity. Let's get rid of this. So propagation velocity, what chamber do we take it from? What view do we take it from? Apical 4. Good. So we run it right through the apex, right through the middle of the valve. So remember, that's different from MAPC. MAPC, you're running it through the annulus on the outside, on the lateral wall, and through the Doppler. So we first of all stick color Doppler on before we go into M mode, and then you stick your M mode cursor through and then run M mode.
Velocity for the
These here, yeah, that's a good point. So this is, do you guys remember what your velocities were measured the other day-ish? It's probably going to be around 40 to 60 centimeters per second. The biggest problem on this, just to give you a heads up for lab, is high PRF. So you guys have talked about high PRF, I think, in physics, right? Mm-hmm. So it's HPRF. And what does that mean?
It's pulsing.
So it's high pulse repetition frequency. Why does the system do it? Okay. So it's taking multiple gates. So once that pulse repetition frequency has exceeded its limit, it adds another gate at a different level. So the downfall or pitfall to that is that you're sampling two different things at the same time. So you got to be careful of that. The reason it does it in pulsed wave is because in vascular, you don't have the option to use continuous wave Doppler, unless you use a pencil probe. In echo, we do use continuous wave Doppler. So in echo, you basically never want high PRF. And for this waveform here, let me just draw out what we're looking at, our view. So 4-chamber view. We're looking at that pulmonary vein at the back that comes in. So this is the right upper pulmonary vein. That's a V. And then we're sampling it deep inside here. Now if I've got this set up nicely, and say I kick into high PRF, the PRF is going to be determined by your depth. So if you could be in there and it could be set normally, and I move my cursor down just a little bit more, high PRF will kick on automatically and you won't know that it's doing it unless you're looking at the cursor in the reference image above. You know, if the other cursor's out here, probably not a big deal, right? Because there's no movement. Well, I mean, there's movement, but there's not high velocities out there. If my cursor happens to come right here, I've got a very intense waveform happening right there that's going to overpower this waveform because this is very slow velocity. Low flow, more difficult to see. So anytime I get a sample gate that comes in a more intense waveform, that's going to overpower what you see. So the way to fix this is to decrease your scale. Okay? If my scale's set too high and I move my depth all the way down, high PRF kicks on automatically. You're going to have difficulty even seeing a waveform. It's going to be a lot of noise, and that's because of the high PRF. So to fix it, drop your scale down and on the spectral scale, and then it should be fine. Okay? The other trick is on getting a good waveform of this is making sure that you can see it in color really well first. If you don't see it in color, you're probably not going to get it in spectral. Okay? So again, usually I actually move my transducer laterally over to this position, so I've got a straight shot through that. We get a lot of shadow that comes across that septal interface that usually hides that. So the more right over top of it I am, the more we're not going to see it. Okay, so come and open it up, get everything else out of the way, and then you'll see it clearly. Good, so yeah, scale around this, the upper part is going to be probably around 40 to 60 centimeters per second, but it could vary. I mean, each person's a little bit different, and that's okay. All right, so propagation velocity. So first of all, have we diagnosed that this is impaired relaxation? Yeah, right away from our mitral inflow. The other stuff is just adding information, like, yep, it's still that. So in propagation velocity, again, we're seeing a mitral valve kind of open. As soon as it opens, we get our color fills in. Okay, and it kind of, it's in Reynolds, if you have it, it kind of draws it out like this. This is just the aliasing velocity that's going around there. And all we're doing, again, is measuring the slope of that. Okay, in M mode. So propagation velocity for normal is above 55 centimeters per second.
Can you repeat that, sorry?
Yeah, the propagation velocity for normal is above 55, so greater than 55. For impaired, for this level of diastolic dysfunction, we're looking above 45
Centimeters per second.
centimeters per second.
So impaired is above 45.
Yep. Okay, so above 45 centimeters per second for that. Okay, again, pretty simple measurement to do. Just run that color Doppler, run the cursor through it, do the M mode, and then measure the slope. It's an easy measurement. Okay, so for this level, and 45 is going to be our number beyond this, and it's going to be either greater than or less than 45 at this point. So it's just one number to remember for that. We forgot to talk about the velocity of the mitral E wave. So on grade 1, or impaired relaxation, we're talking less than 8 centimeters per second velocity on tissue Doppler, on the E prime. Okay, normal is anything greater than 8. Now it's anything less than 8. Okay, so 8 for tissue Doppler is the same number across all of these. It's either greater than or less than that. Okay? And I'll give you a hint. Beyond this, they're all less than 8. Okay? So impaired relaxation, tissue Doppler, we go less than 8. Good. Any questions on impaired relaxation? So just do a quick diagrammatic reference to impaired relaxation. So if we're looking at a column of stuff, so our mitral inflow, it looks like what?
For propagation?
So Valsalva, oops. Valsalva, same relationship. So this is,
Is this the same?
we'll just call it inflow. Valsalva, TDI. Hold on.
We're doing normals.
I was drawing normals. I'm meaning to do impaired. That's right. And then pulmonary vein, bigger S, smaller D, there. And I'm not going to drop propagation velocity. They're going to look similar. You're just really looking at what the slope is on those. So, quick format, that's essentially a diagnostic for that. So, again, take the 50-50 visual right off. I'm going to be doing it all as a column of information, multiple pieces of information that should tell you roughly the same story. In a real world situation, some of my numbers may be kind of borderline, and some may suggest it's normal, some may suggest it's impaired. It's going to be kind of like, you know, if 3 of them show me abnormal and 1 shows me normal, I'm going to call it abnormal. If 3 of them show me normal and 1 shows me abnormal, I might question the measurement I did. So you just use all of your information that way. Okay? The more pieces of information that's supported, the more likely that is the case. Okay. Next phase, phase 2. So we used to do this as 3A and 3B. I just noticed in ASC this is going to be grade 4 on that one. We're not there yet. Okay, grade 2. What is grade 2?
I think you forgot the E.
Probably. Thank you. It's not like I'm being recorded or anything. All right, so pseudo-normalization. So what does pseudo mean? False. False normal, okay? So it looks normal, it's deceiving. And again, the term that I used before is called unmasking. So I want to take the mask off and show what it really is, okay? So first of all, mitral inflow. What do we see on mitral inflow? Okay? So this is why it's called pseudo-normal, is because it looks like the normal did. So my E wave is higher than my A wave. And again, I draw it like this, but don't be thrown if I throw, you know, do a full diastasis type of flow in there. That's okay. And there could be greater difference on timing of these events too, depending on what my EKGs and how fast the heart rate is. The faster it goes, the more it's going to smush together. So don't be thrown by the distance between that either. So that's our first clue that, hey, things are looking good. So I've got my 70-year-old patient that I'm scanning, and I see this flow. It's like, yeah, we're good. We don't need to go on. They're normal, right? Right. Good. All right, so I'm scanning a 25-year-old patient, and going along, and I see this. We don't really need to, we're going to do the information anyway, because we typically do, but we don't really need anything beyond that on a 25-year-old, right? Is it likely that they're normal? Mm-hmm. Yeah, it's likely that they're normal. So I wouldn't be concerned about having to make sure I get all that other stuff. But a 70-year-old, I do not expect to see this, right? So it's kind of that relative age thing. So that was mitral inflow. What about Valsalva? This is where Valsalva does make a difference. Okay, so we do Valsalva. What do we expect to see with that? Okay. And not super small necessarily, but it reverses. It changes that relationship. So my E wave is now smaller than my A wave.
I thought it just made it just smaller.
So the first two, on normal, it will make it smaller. On impaired relaxation, that relationship's already the E smaller than the A, and they just depress. In this case, it will depress it, but now this actually forces my E wave to become smaller than my A wave. This is really your first clue that this is a pseudo-normalization. So I got a normal waveform, and it changed with Valsalva. Now again, do I need to do Valsalva to diagnose this? No. I mean, back in the day before we started doing tissue Doppler, we did have to because we didn't have another mechanism to do that. So now you can live without doing Valsalva and you just get your information from other sources. However, Valsalva is not very hard to do. I'm already on that valve. I just have the patient hold their breath, bear down, and see what results I get. Worst comes to worst, this doesn't show me what I think I'm supposed to see, and my tissue Doppler does. I can just exclude this piece of information. But if I see that it does reverse, that just helps prove the case. Does that make sense? Good. So that's what Valsalva does. So, you know, it may show normal, it may reverse. It depends on how well the patient does it. But I still personally think it's a good piece of information. Then we got tissue Doppler next. So what do we see in tissue Doppler?
Basically a mirror image of your Valsalva.
So mirror image of Valsalva, yes.
Yeah.
So relationship of E and A, E is smaller. Okay. So tissue Doppler is really the diagnostic tool to say this is definitely pseudonormalization. It's a pretty consistent, reliable thing without being patient dependent. Okay, so this I would really hang my hat on pretty heavily for that. So once this shows a changed relationship, it stays that way pretty much. Okay. Now, as this same patient, if I'd scanned them 15 years earlier and they had some impaired relaxation, it still would have had this EA relationship. Okay, it would have been impaired back then. So it pretty much stays this way throughout now.
Are all the scales the same as impaired, or are you gonna like shrink them just a little bit?
The scales should be around the same. It's just where do I generally set this up when I go in to do my Doppler. You'll customize it depending on the patient, and it will vary some. This one is going to continue, the velocities will continue to get lower and lower. So E prime velocity for this wave is going to be, and it's average between the septal and the lateral wall. Remember, this is less than 8 now. Okay, and it's going to stay that way from throughout. When we get into the restrictive pathologies, then it's going to get actually very small. It's going to be down like less than 4 centimeters per second. So we're talking super small. So if you got your scale set up at 100, you're not going to see it very well. Okay. Good. And what's after that then? So then we get into pulmonary vein. So what do we see on pulmonary vein with the SDs?
Yes, it's smaller.
Okay, so now I get a smaller S and a larger D. And my A wave?
It's bigger.
Okay, so it gets wider and taller. Okay, this is where it really starts to change that A wave. So my A duration at this point is going to be more significant, as well as the height of that, the centimeters per second. So again, let's see. So my AR velocity now is greater than or equal to 35 centimeters per second. Okay, so this is grade 2 pseudonormal, and it stays this way beyond, from here on out. So the restrictive patterns also have this same relationship. So but as we get further and further, it gets wider and it gets taller.
Can you say the propagation velocity again?
Propagation velocity is now less than 45. So the impaired relaxation was greater than 45. Normal is greater than 50. Now it's less than 45, and it will stay that way throughout. Okay. And the duration of the A wave, let's see. Forget that. We'll just leave it at that. So again, visually speaking now, again, the major diagnosis is I've got a normal looking mitral inflow. Okay, it switches. It may or may not switch with Valsalva. I'm not super concerned about that, but a proven one where it does switch just says yes, it's definitely pseudonormal. This is going to pretty much tell me that it's pseudonormal. This information is going to be supported by it. So I've got a bigger, wider, and taller than normal A wave duration, the AR, and my S wave is smaller than the D wave. Okay, so visually speaking, that group of information is going to tell me pseudonormal. It's good. The easiest way is going to be just telling between these two, and everything else is just going to support that probably.
With the numbers for the propagation velocity,
Yep.
do you want us to know what's based out of what you say is at the ASE chart?
Generally speaking, I'm going to try to get everything out of ASE because that's our standard for most of our echo sites.
Okay.
There might be some variation. Don't be thrown when you go to clinical if they use different numbers. As long as that lab uses the same numbers for all their studies, you're fine. So they may change, and each year they do studies that disprove it's not that they disprove, but they change what they think the parameters are.
Okay.
So you'll see numbers change over time, and that's okay.
Yeah, I was just going to say, I don't think there's any numbers as far as A duration in the chart in the slideshow. Do you want us to know those just for... No,
it's just, I'm going to just throw them out there for numbers right now, but again, you can tell everything that's going on almost solely based on the pictures right now. Okay? Some numbers will be important. Again, these EA ratios are important. It's that reversal that we're looking for that's significant. The next one that we look at, grade 3 and grade 4, the EA ratio is going to be an important factor. Okay, so we're good with propagation velocity. I'm not going to draw it up there, but again, propagation velocity again is less than 45 at this point. So pseudonormalization is less than 45. Impaired relaxation at grade 1 was above 45.
And that's just the slope, like it's.
Yes. Okay. All right, let's leave the labels up and change this. So this is now grade 3. So this is restrictive reversible. Okay, so let me just explain briefly what a restrictive physiology is. So the whole concept with diastolic dysfunction is that it's not relaxing the way it should. It's not quickly relaxing, it's not compliant. Because of that, as we go further along, if you'll notice in some of those charts, it will give kind of a bunch of arrows up and down for LV relaxation, LV compliance, and atrial pressure. As we go further across those, like the atrial pressure, for example, goes up and up and up. Okay, so I'm looking at pressures. The worse down this cascade I go, the bigger the atrial pressure is. And typically LV pressures also. So that backup of fluid and that lack of functionality is just causing a big backup of problems. All right, so mitral inflow, what does that look like for restrictive? So again, sorry, restrictive is now, this is a fundamental issue with the muscle itself. Okay, so this is something's going on in the muscle that's causing it not to function properly. Most people, even if they die of heart disease, most people in their age are only going to get to the pseudo-normal stage. Restrictive is kind of that next level of bad, okay, where most people don't experience that. They'll die from something else or some other heart-related cause. So if we're seeing restrictive physiology, that's pretty advanced. So mitral inflow, what do we see there? So impaired relaxation, we saw a reversal of ENA. Pseudo-normal on the inflow, we saw a normal looking pattern. Now what do we see? E is still greater than, but
Much taller
A
and
is smaller.
pointier.
I'm going to draw this. Now the decel time we talked about before was pretty much normal decel times. Now my decel time is getting less. It's dropping off super quick. Okay? So I'm going to get a relationship more like this. Okay? So what is the ratio of the EA ratio here? So E is just taking the peak of the E and divided by the peak of the A. That's what gets my EA ratio. So what is the EA ratio for restrictive?
Greater than 1.5.
So greater than 1.5. Okay? So that means it's at least, the E-way is at least 1.5 times taller. Some charts may even show it as 2 instead of 1.5. So it's significantly taller. So taller and a very quick deceleration time. So now we're getting into less than 150 on your deceleration time. Normal is 150 to 240. Okay? Impaired relaxation for the decel time is greater than or equal to 240. Pseudo-normal does come down, it goes 150 to 200, and now we're less than 150. So it's a very, very steep drop on that. So that should be the main thing. Valsalva on this. So now I'm doing the same waveform with Valsalva. What do we see on that?
E-wave's smaller.
So now I get that reversed E wave. It might still be spiky. Okay, but I got a reversed relationship. So what's the number on that? Just less than 1?
It's 5.
Less,
Point
0.5? Okay, so Valsalva helps on this as well, if Valsalva is done properly. We'll always put that caveat. So this is the distinction really between restrictive reversible and restrictive irreversible. I can't switch it, okay? This can be medicated, this can be treated to some degree. It is advanced diastolic dysfunction, but it's still treatable. When we get to the next level, it's not treatable. This is kind of end-stage heart disease.
Is the ratio for the Valsalva, I think it's greater or
It
equal
says
to
greater than
0.5. If it's less, it's the fixed.
Oh, yeah, okay. Sorry, thank you. So greater than 0.5, but it is reversed, so it's less than 1, between 0.5 and 1. Pretty much. Once we get to the next level, that's when it gets even worse. Okay? Something like that. Okay, then tissue Doppler. I think all it said on tissue Doppler here was that that this is less than 8, right?
This is greater than 10. Greater than equal to 10. Your E and E
That's for the
prime.
E.
prime. E and E prime is.
Okay, E to E prime. Okay, so that's don't get lost on that because the tissue Doppler velocity is less than 8. So the E to E prime is different. What does this mean? So that is this waveform as compared to this waveform. So don't get lost in this. So that's greater than 10. Okay, and that's just a ratio. That's not a velocity. So velocities, I am less than 8, but from experience, I will tell you that's usually like around 4 centimeters per second. It's significantly low on these. All right, and then propagation velocity, just like the others, once we hit pseudonormal, is less than 45.
Pulmonary veins.
And the pulmonary vein, A velocity was less, or I said less than, greater than 35. Yep. And what do my S and D and stuff look like on that?
S is smaller.
And D is bigger. And remember the A wave now, we just continually get bigger and wider. Okay, higher velocity and wider. So if I'm following this patient up, once it hits below 35, that's fine for diagnosis, but if I'm following up this patient, I scanned him a year ago, now I'm scanning him again today, I expect to see wider A duration and a higher velocity on that AR. Okay. Good. So let's leave for the restrictive irreversible. Let's put that as IR. Okay, so now this is significant for irreversible. Because this again is kind of end stage. This is now, I can't make the change. They're less likely to be tolerant to medication changes and stuff like that. It's end stage disease. I'm going to leave this up here for now. So we still have this. Do we have any other distinctions on the irreversible? So E is much greater than by more than 1.5 times. Often you'll be up around 2. Valsalva, okay, but it doesn't reverse, right? So might dampen it. My A wave is getting closer to my E wave this again. Okay, so this relationship didn't change as far as the ratio of the E and A goes. And tissue Doppler. Yeah, I mean, at this point, they're very low velocity. Like I say, it's less than 8, but it really looks like about like that. They're like really stumpy nothings. Okay? And pulmonary vein?
S wave is small.
S wave is small again, so it's not much different from what it was before. And I'm just going to keep drawing that bigger as we go.
What's the E to E prime for TEI on this one?
Still greater than 10, yeah. So really, what's the differentiation between this irreversible and reversible?
Valsalva stays the same.
It's really Valsalva. Okay? So if I don't have other pieces of information that are going to significantly change my diagnosis, doing a proper Valsalva here is going to be important. Okay? All right.
What's the propagation velocity for this one?
It's again less than 45. So that doesn't change. I'm just looking at this chart real quick. So I never wrote it up here, but just an additional piece of information if you wanted was the IVRT. So the IVRT, remember, is the isovolemic relaxation time. So that is after the LVOT flow and before the E wave. Normal is 70 to 90. Impaired goes greater than 90. Pseudo-normal goes back less than 90. And then the reversible, both restrictive and reversible and irreversible are less than 70. So again, they don't differentiate between each other on that, they're just less than 70. Deceleration time is, I think I mentioned, deceleration time on the restrictive is less than 150. Good. That's diastolic dysfunction. So, know it in the groupings. So I'm not going to probably give you like one piece of information on that. I guarantee you that this chart will be on the test with, and again, I'll put them in columns. So it'll be a full grade 1 profile versus a full grade 2, grade 3, grade 4, or other names, impaired, pseudo-normal, restrictive, reversible, restrictive, irreversible. Okay? And that's essentially what we're going to do. So when you're scanning, what do I need when I go in the room?
Person.
You need a person, yes, absolutely.
Ultrasound machine.
Let's go.
Gel.
Let's jump beyond that. What images do I absolutely have to obtain?
Apical 4.
It's apical 4 with
Valsalva.
mitral inflow.
Mitral.
Got to do a Valsalva on the mitral inflow.